My topic is Tetralogy of Fallot, and I will briefly be touching on all of the main points. To start, Tetralogy of Fallot is a rare condition comprised of 4 different anatomical defects: ventricular septal defect, right ventricular hypertrophy, pulmonary stenosis, and an overriding aorta. In this picture, you can see the differences between a normal functioning heart and a Tetralogy of Fallot heart. Every year in the United States, approximately 1,660 babies are born with TOF. If surgery is not performed, up to 35% of these babies will die within their first year of life. Although the primary cause is unknown, some cases are thought to be associated with genetic mutations, such as trisomies 21, 18, and 13, or deletions of chromosome 22. Certain environmental factors may increase the chances of TOF. For example, if the mother and fetus are exposed to phenylketonuria or retinoic acid, or if there is untreated maternal diabetes during the pregnancy. Tetralogy of Fallot is not limited to a specific race, ethnicity, or gender. Therefore, it may present equally among any population. Cyanosis, the main sign of TOF, presents as blowing of the skin, lips, and nails caused by low levels of oxygen. Episodes of cyanosis during crying or feeding are called tet spells, as you can see in this picture. A characteristic compensatory mechanism of squatting is highly typical of infants with TOF and is of diagnostic significance. It increases peripheral vascular resistance, which decreases the degree of the VSD shunt and gives the patient some relief. Poor feeding and failure to thrive may also be seen. On physical exam, along with the presence of cyanosis, a harsh systolic ejection murmur may be heard at the left sternal border over the pulmonic area. Clubbing of the fingers and toes may present after 3 to 6 months of age, but it is now highly unusual because TOF is surgically corrected before the patient has time to develop the clubbing. Providing a cyanotic infant with oxygen supplementation may help a practitioner distinguish between a cardiac or pulmonary problem. If the oxygen saturation improves, then the problem is pulmonary. However, if no improvement is observed, then the problem is cardiac. To accurately diagnose TOF, Doppler echocardiography must be used and is the gold standard for diagnosis. Echo may capture the degree of the overriding aorta, the size of the interventricular communication, and any other lesions present. This now commonly occurs in utero during mid-gestation. If EKG is performed, right axis deviation and prominent right ventricular hypertrophy will be observed. A chest X-ray may reveal the classic boot-shaped heart, which is considered the hallmark of TOF. A CBC may be performed to find potential anemia and thrombocytopenia. Patients with TOF may also be at risk for bleeding due to decreased clotting factors, resulting in prolonged coagulation times. An ABG may be significantly abnormal and may be helpful in dark-skinned or anemic patients who do not have apparent cyanosis. Management of TOF includes both physical and pharmacological measures. Physically, during a hypercyanotic episode, the infant's knees should be brought to the chest in a tucked-up manner, which decreases the degree of the VSD. The definitive treatment is corrective surgery. If the patient cannot tolerate corrective surgery, palliative procedures such as placing a shunt in between the pulmonary and subclavian artery may be required. Pharmacologically, morphine and phenylephrine both have positive effects on systemic venous return. Propranolol relaxes the infundibular muscle spasm, improving right ventricle outflow tract obstruction. Prostaglandin therapy may also be used to keep the ductus open temporarily. As far as consults go, regardless of treatment choice, all providers caring for patients with TOF should consult pediatric cardiologists and pediatric cardiac surgeons. As the patients enter adulthood, specialists in adult congenital heart defects should be consulted. Surgery is the definitive treatment, but when to get surgery done is still controversial. Arguments for an earlier primary correction of TOF has been made in support of the recent series of patients who underwent surgery in the first few months after birth and showed exceptional early and 5-year survival. There are 3 techniques of corrective surgery that can be used: transventricular, transatrial, or combined atrioventricular. A study was performed that showed that the combined atrioventricular approach had lower complications than the other 2 approaches and proved to have an excellent survival rate of 97.5. The goal is to close the VSD, eradicate the area of stenosis, and repair the right ventricle outflow tract obstruction. Since the primary cause of TOF is still unknown, preventing the development of this condition is improbable, but it is important to inform parents that newborn screening using pulse oximetry may be performed in an attempt to catch the condition early. In those patients who have been diagnosed antenatally, Parents should be offered counseling and should be encouraged to plan their delivery at a center prepared for a cyanotic neonate. For those who are not diagnosed antenatally or at birth, it is very important that parents are educated on possible life-threatening emergencies, such as hypercyanotic spells. Parents of a patient with TOF who has undergone corrective surgery should be aware that there is approximately a 5% chance an additional surgery will be required at some point. This concludes my presentation. I hope it was helpful and I wish you all the best of luck.